So let's get started. Cognitive function disorders. This is actually kind of a brief, down and dirty discussion about Alzheimer's. That is my focus, Alzheimer's. So let's get started. So several things to know about Alzheimer's. It's a chronic brain disease. It's the most common form of dementia, which I find very interesting. It does cause brain atrophy over time, and that's why we have loss of memory, problem-solving skills, and a decrease in communication and mood swings. So we're going to have this altered mental state. It's the 5th leading cause of death among adults over the age of 65, and this is all per the CDC. 6.2 million Americans have Alzheimer's, and women are most likely to develop it than men. Why? The reason behind that is because women still at this point outlive men. So we'll be at a higher risk for it because we live longer. No one knows why Alzheimer's exists, and there is no cure. But there are medicines that can help, and we'll go over this in this actual presentation. Now, the way for testing for Alzheimer's is there's no exact, and it takes multiple tests to really get a true diagnosis. And a lot of it's symptom-based, so the memory loss of wandering, all of these things that we're going to talk about, we start to see, and that's when the diagnosis can take place. But there is some testing that we do. So we can do cognitive assessments, going through testing their cognitive skills, mental evaluation, looking at all of what I just talked about, MRIs, so we're going to take a look at the layering of the brain, see if there are these plaque buildups that can cause the disease. They're seeing this correlation. CT also, we can see some things going on. There are biomarkers, and the way we get our biomarkers is we do a spinal tap. So we'll have the patient position, go in, actually get spinal fluid, and look at that to get these biomarkers. Now, saying that, one of the things, if you think about this, if I'm nursing, I need to understand a spinal tap, right? Well, for my students right now, they don't really need to know that post-op care of a spinal tap, but for anybody else, just so you know, we keep the head flat for so many hours post-spinal tap so that they don't have any leaking cerebral spinal fluid, CSF. And we want to make sure, because we've altered a pressurized system by accessing it, we can get these, the patient can get horrible headaches from it. So we need to understand that and be able to explain it to the patient, and that's why we keep their head flat. They're not thrilled with it, but we need to. Blood test. We can also look for beta amyloids. These are amino acids that form plaque in the brain. That's what we're looking at. So what has happened over time is really they have to look at a deceased patient with Alzheimer's brain to be able to identify and diagnose these patients and get the understanding of what's happening in the brain once the patient has passed away, so post-mortem. But we are looking for diagnoses, so we can start to look at these things plus signs and symptoms and everything going on to get that diagnosis. So let's talk medicines. So there's very few medicines for Alzheimer's. I really want my students to focus on these medicines. There are cognition-enhancing medicines. The drug class is central acetylcholinesterase inhibitors. We're looking at donepezil, which is Aricept, and that is the drug that I really want to focus on. Side effects are nausea and vomiting, diarrhea. So we always want to give this medicine with food. It can cause muscle spasms, but also note it can cause bradycardia and syncope. So we want to be very careful that we're monitoring their pulse and their heart rate. If they have a low pulse and they take other medicines that can lower their pulse, we need to really look and evaluate their medications prior to getting them started on Aricept. And then while on it, if they are on other things that can lower their heart rate or cause a syncopal, lower blood pressure to cause a syncopal episode, then go ahead and monitor and look at those medications also. Monitoring is the key, looking at that pulse and blood pressure. If we overdose on Aricept, we can have severe bradycardia, increased muscle weakness. So we already have some muscle spasms going on, but if we take too much of this, I mean, it's difficult to pick something up and hold it. It's difficult to get up and move completely. You know, they're just at this severe weakness. And a very severe or decreased low blood pressure. So those are the things that are significant of overdose or too much of Aricept. So we need to be very careful. The other thing I want to talk about Aricept is we never want to stop any of these medicines because we can have a rebound effect. So we need to be very, very careful. They also can cause dry mouth, so telling them to chew on sugar-free gum or to have some type of something to help take sips of cool liquids, different things like that. For my students, just so they know, there is a box on this medication on page 1081, chapter 46 in your Stromberg book. So just so you know. Another medicine to look at is the NMDA antagonists. These are the excitatory transmitters. The drug class is NMDA antagonists, and it's Namenda or memantine. Side effects are headache, dizziness, constipation. Constipation can be with Aricept also. So what do we do for constipation? Increase fiber, increase fluid. It can cause a cough. It is can cause hypertension, liver failure, and it's renal toxic. So one of the things we would do is if they're on this medicine for a long time, we'd want to definitely check liver function and renal function through labs. They can take it with or without food, just so you know. Now, Aricept causes all the GI upset, so we want to take it with food. We want to make sure we take it with food. This one, it's either or. And as far as times for these medicines, they can be given at any time, but you want to be consistent. So whatever's good for the patient, where they can remember to take their medicines if they're still there, what's the best time frame, in the morning, in the evening, whatever. But they need to be consistent, around the same time, and make it convenient for them. Just so you know, one of the things I did make a note of down here is a lot of anesthesia medications and seizure medications can interfere and it can be detrimental with the patient taking Alzheimer's medications. So I don't necessarily think you need to learn all the anesthesia medications or seizure medications, but I want you to understand that if I have a patient that has a seizure history taking seizure medications, and now we're dealing with Alzheimer's and going to start to give medicines to help with that, then what we want to do is go ahead and have them not take those medicines or talk to their physician about it actually. So the A's have it. Always need to know your A's for this. Aphasia, you should already know. You can't understand or create speech. They're aphasic. Apraxia, can't perform certain motor movement. Agnosia, can't recognize objects, people, or sensation. And when we say sensation, this is where we have people that they don't have the sensation to go to the bathroom, so we have incontinence. And so when you see this, these are those patients. Amnesia, total memory loss, and anomia, you can't recall names or objects. So these A's you should know, it will help. It's in the lingo of Alzheimer's, but we see this. These are the things that we see. Just remember that. Okay, there are stages of Alzheimer's. So we have preclinical stage, and that means things are just starting to happen, and it's not impacting anything in the patient's lives. They don't even know. That's probably like a lot of us walking around, which is kind of scary in the grand scheme. But this is a preclinical stage. We're not even anywhere, you know, there might be a drop in a word or something like that, but it's nothing that anybody can pick up on, not the patient nor the family or their loved ones. The next stage is mild cognitive impairment. So we have subtle memory changes. They feel that they can't think clearly. This is where it's like, oh, I'm kind of foggy. I'm not real sure. And they forget about recent things, so like appointments or something going on. They just kind of forget. And this can happen for several years. They can start to have this mild cognitive impairment before it moves on. Now, some people can pick up on this, but some not, because sometimes we're so overwhelmed and stressed, we can't remember things. And it doesn't mean we have Alzheimer's. So lots of times this will go on for years, and then once a diagnosis takes place, as things progress, we go back and remember, oh yeah, by the way, mild cognitive impairment. You know, there was some there. We just didn't realize that was what was going on. So the next stage is the early stage, which is a mild Alzheimer's disease. It's considered the early stage. This is usually when the patient's diagnosed. You've got to remember this is frontal lobe atrophy, so it's the front of the brain. This is the stuff where, you know, with cognition, with memory, that kind of stuff. So we have this going on. Others notice it, the mild forgetfulness. This is where the family members are starting to pick up on things. The patient's picking up already on it, and now it's getting to where it's noticeable. They can't learn new material. New material can be presented, and they're overwhelmed by it. They just can't seem to get it to work, to get that information. But they can still function. So they're still able to do stuff that they already have learned, that they already know. So they can go on with life. And this can last several years too. And they're independent at this time. So there's days that are good days and days that are bad days. But some days that everything's clicking and great, and some days they struggle. And so this is where we start to see. Now this is the time that though they're cognitively completely still there and able to make decisions for themselves. And this is the time to talk about the end of life. Because it's going to progress. And as we teach our patients, we have to teach them that there's no cure. This just gets worse. So what do? We want the patient to be able to talk about what they want and how they want their end of life care to be. And this is the actual stage that needs to take place. So once things start to happen and the diagnosis comes forward, then that's time to sit down and let's really start to talk. And it can be very difficult because it's a shock for people. So the next stage is moderate Alzheimer's, middle stage. Confusion is really starting to interrupt their ADLs and their functioning. They're going to need help and supervision. Wandering will begin. They can get lost. They can start the wandering process in their home, looking into room to room, looking, you know, just wandering throughout the house. But you notice it. It's something there. There's a lapse in judgment. They're not going to be able to make certain decisions. In this stage, it's difficult for them. So lots of times giving them simple direction, and single direction, one direction at a time, simply put, and never, you know, getting angry with them or upset if they can't do it. This is a great time to walk them through things, label things, lay out clothes for them, different things like that. And they might need some help, but most of the time they can still do for themselves. They just need the reminders. Mental instability, they can get angry, they can be very anxious, have anxiety, hallucinations, and they have a definite decrease in their cognitive ability. So the problem solving, things like that can become difficult. Sundowner syndrome, it's present, it's real. This is when the sun starts to set that they start to really become severely confused. The thing with sundowners that we need to know is they need to get up in the morning. We can't let them sleep all day and then get up as the sun starts to set again and then they go through it. So it's getting light in, going in, stimulating them to try to keep them where they'll sleep at night, hopefully, and you can assist with that. Also with sunlight, just so you know, it will help with depression. If you are having issues with depression for these patients and depression can fall along with Alzheimer's, getting out in the sun is a great thing. Or getting in sunlight through the window, you know, open the blinds up. I believe in that. I'm going to tell you something too, just a little quick nugget, is that anybody that sits in a hospital for a long period of time can have confusion. So it's so important that we remember that in the daytime, even if they're sleeping in the morning, you know, opening up the blinds so that they understand it's day, and what's night, because they'll lose days and nights and dates and what is it, Monday, Tuesday, Wednesday. So it's important that we help with that. It is the longest stage, the middle stage of Alzheimer's. The next is the severe Alzheimer's, or the late stage. This is the end stage, the last stage of it. It's severity of symptoms. So all the symptoms they've had are still, they can even be in a fetal position at this time. Decrease in communication and language. They're not able to communicate, a lot of them, at all. They will not speak. Dysphagia, they're going to have swallowing issues, so they're at a high risk for aspiration. So we need to be very, very careful of giving them. Lots of times it could be tube feeding, or at least thickened foods if needed, you know, and they will be fed. They're feeders. Need continuous care. There's no leaving them alone. They have to have full ADLs completed for them. Continue to communicate though with them. Don't stop talking to them. Don't stop touching them. They need a calm environment. This will help soothe. Also, there is a person in there, and we want to love them and be there for them as we work and help to provide the care that they need. Nursing. Now, this is where we get in. We want to educate on the progression of the disease for the patient and the family. They need to understand these stages. Medications, discuss what they are, when to take them, the side effects of them, that's in the slides previously, and never stop them abruptly. Discuss the importance for caregivers to take a break. Respite care is a good thing to support this. The patient can go to respite care and the caregivers then can have a break. Can be very taxing to deal with someone 24/7 with memory issues and this process going on with their brain. It can just be exhausting. So it's important that we don't allow exhaustion to take place with our caregivers, because then they can lash out at the patient or become angry with the patient. And we don't need that, because it can become very frustrating. So we need to explain that this can happen and what they can do and the resources that are out there for them. Also identifying signs and symptoms for the patient and family. They need to know what the signs and symptoms are. And they need to note and watch, because they're with the patient all the time, that if things worsen, and make notes of things. It's good to journal, or the caregiver journal, the family member, but the patient to journal themselves if they still can. Now, as they progress, they're not going to be able to. But for the family and the caregivers, actually journaling their progress is so important. It will help. So really quickly, the 7 M's in nursing for an Alzheimer's patient. Memory. We want to reorient them to person, place, time, event, whatever. We need to reorient them. Simple instructions should be given. If the patient doesn't do not reprimand or scold them. Do not get onto them. Don't argue with them. You need to stay calm. If they're struggling, this part's not working for them. Movement is the next one. Independent as allowed. Let them do as much as they can, as long as they can. Routines are so important. We do them for children or babies, infants, routines, because that helps them with sleeping and eating and all that. Routines are good for your pets. Routines are good for us, but routines for memory are wonderful for Alzheimer's patients. And also make sure that they exercise and move. This, just because they have Alzheimer's doesn't mean it's time to sit in the chair and not do anything. So exercise is important, and what they can do. There's different exercises out there. Also, exercises help exhaust the patient or the person, and it'll help them to relax with stimulation. Mental health, calm them, distract them, slow and easy, slow and easy. I can't say it enough. They could have hallucinations at this time. It's so important with hallucinations that we not tell them, no, that's not there, but to reorient them, provide proper lighting, bring them back to reality, and then assist or help them, instead of just saying, that's not over there. You don't see that squirrel on the wall. There's no squirrels here. Instead saying, okay, let's turn on some lights, let's get up, let's go, take a walk in the hall, whatever's needed. But calming them, and coming back in and reorient. This is your room, this is your bed, these are your belongings, so that they understand and hopefully can come back. Remember safety, keep everything well lit. Remember, sundowners, they're going to be really confused. So if that's the case, we need to understand, providing safety for them. Maintain safety with driving. They shouldn't drive after a certain point. We need to understand that, not only just obeying the laws, but remembering where they're going and how to go and things like that. Cooking, there can be fires, burns. We need to be very careful. Any equipment that can harm them. There's a lot. If they were farmers and they're out there on those tractors, they're out there doing balers and stuff like that, we need to understand that that's their memory is there for that. So they might feel the need to go do that. And that is something that could be very harmful. So we've got to maintain safety for them. Wandering will happen. They become lost. So wearing a medical ID, identifying them and someone they can contact is important. Also an app on their phone to help them before they lose this, that if they do have a moment of fogginess or memory lapse, they could go to their phone and hopefully direct themselves. It'll also ping them. We can follow them, a loved one, knowing where they are at all times. Now, the thing with that to me is if they lose their phone or something happens to their phone, but you can do it all. You know what I'm saying? Locks on doors, things like that, where they can't just, when they get to a point where they can't just wander out into the cold or into the heat right now. Maximize communication. There's going to come a time where they can't communicate. They're going to have difficulty communicating. Find a way to communicate. If it's through touch, if it's through pictures, if it's through labels. Don't ever stop communicating with the patient, even if they can't communicate back. It's so important. We just need to make sure we really work on this. It's hard for us if we talk and communicate all the time to have to use other methods of communication. Always remember your nonverbal communication, touching softly, touching calm, staying calm, talking calmly. If it's a really wild environment in the home, calming that down so that the patient can stay and not get anxious and all of that. It helps with that mental health piece. Continuing with the communication, give one direction at a time. I've already said that once. It's so important. It's like, go ahead and pick your shirt up. If they haven't picked their shirt up, don't go ahead and tell them to put their shirt on. At this point, they need to pick their shirt up. So giving the one direction at a time, you might have to repeat the direction over and over, and that's okay. Take your time and allow the patient to take theirs. Don't rush. There's no rush. You take your time in asking and allow the patient to take theirs. I think sometimes we can give the direction and we want them to do it, but it takes a moment. They've got to bring it together. So let them take their time. And you can repeat the direction. There's nothing wrong with that. Yes, no questions are appropriate. In nursing school, we always talk about open-ended questions for the Alzheimer patient, and yes, no question is very, very appropriate. Because that's a one single answer. They can say yes, no, they don't have to go in detailed. It's like going into a restaurant where you have 17 pages of a menu to pick something out to eat. Sometimes it's so easy when you have that little menu of 5 items. This is what I want. Same kind of concept. Do not argue with the patient. Do not argue with them. They are going to argue with you if you argue with them, and we don't want that. With that mentation altering and the anxiety and anger that can flare up, we want to make sure we stay face-to-face with the patient. You don't want to be coming to the side. It can startle them, and immediately they might become combative or coming from behind. They're going to defend themselves. So it's natural to do face-to-face. Let's stay eye contact. You don't want to put them down lower. They're going to feel like you're overwhelming them, over top of them, and that can cause them also to lash out. These are at the later stages when they're having issues, but we need to think about this as caregivers. It's easy to put somebody in bed and just lean over and think, because we're doing what we're supposed to be doing. It's task-oriented stuff. We need to think now, critically think. Let's stay eye level. Now, you're not going to get down, but if a patient's really having an issue or problem and you want to soothe them, you can get a chair up to the side of the bed and soothe them. Also, explaining all of these things to the family members or the caregivers is important. So to continue on with the 7 M's in nursing medical needs, they need help with their ADLs, they need help with dressing, they need help with teeth brushing, hair brushing. They're not going to do those activity of daily living things, getting dressed properly. Hydration, we have a natural decrease of thirst sensation as we age. And so not only that, they forget to drink, or they have confusion on how to drink, pick it up and take a drink. So we need to make sure that they're getting the hydration that is needed. It's also going to help with constipation. So we need to make sure that they're getting fluids. Weight loss is always present with Alzheimer's patients due to loss of taste sensation. They just don't like the taste of food. It doesn't taste the same anymore. They lose that sensation of taste. So finding things that they will eat is important, and also using finger foods. They're a great thing. They can pick it up and eat it. They're not using utensils, but if they have to use utensils for something that's being given to them to eat or they like, don't let them be eating pudding with their fingers. You need to help them with the spoon. You might need to feed them or assist. Medications, I went over those on previous slides. I do want you to understand there are other medicines out there, and there is a medicine Exelon that can be taken as an oral agent, and then they can go to a patch. The patch is rotated and removed. Or go back and remember you're applying a patch of anything. If it's a nicotine patch or a nitro patch, any kind of patch, what do? Or a pain patch, we don't want to put them on the same place. Make sure, because we don't want any skin integrity issues. So that kind of sums it up. Pretty much this is a great focus for my students on Alzheimer's. Also too, for my students, they can go to their med-surg book and go ahead and look at Alzheimer's. It is on page 1080, chapter 46, and just look through the Alzheimer's section of their Strongberg book. I think that will help also. Hope this helps.